Thank you very much to everyone for joining, and apologies for the very short notice. It's that time of year where everybody's just getting back in after the break, but I see that we have still been able to attract a very nice size audience. So I'm just going to share with you and I hope I can share my screen, the agenda for today. Just please let me know if you can see that. Let me just try and put it onto. Everybody see the agenda, see my slides?
Yes, we can see them.
Yes, we can see it.
Wonderful. So the purpose of this webinar is really an information sharing and matchmaking webinar. And it's obviously directly related to the RFA, which we put out in early January. Which is specifically for HDI capacity development grants for investigator-initiated research on HIV implementation science in a clinical setting. And this is specifically aimed at historically disadvantaged institutions and their researchers. So we're going to start off. I'll give a brief introduction on the RFA. Then Bhakti from Johns Hopkins will give a brief introduction from her side and a little bit of the history of collaboration. We'll have a bit of time to just ask questions on anything that you've heard up until that point. Then we'll have 3 researchers from Johns Hopkins providing a quick overview of their research interests. And then we have the opportunity for anybody from South Africa to present. I've received 1 request so far with a presentation, but of course anybody is welcome to join and to present. We have set aside 90 minutes for the webinar. It may not take that long, but we did want to allow adequate time for everybody to share their research interests and to have some robust discussions, and also, of course, to answer questions. So before I go into the first agenda item, I just wanted to introduce and say a very big thank you to Bhakti Hansotti, who's representing Johns Hopkins University. She's been instrumental in designing this instrument. Together with the MRC, we have a lovely long history of collaboration, and of course arranging the webinar and Johns Hopkins University participation in the webinar. So thank you, Bhakti, to you and your team. I also see Tom Quinn on the call from NIH, and it's wonderful to connect with you again, Tom. And at this point, I'm not able to see all the other participants, but I believe most of the others are from South African institutions. And what I'm going to suggest is that when we do get to the discussion session, anybody who wants to make a comment or ask a question, if you could just introduce yourselves and where you're from. So I think let me go straight into the first agenda item. So the purpose of this initiative, so it's very much a niche RFA. It's not our normal RFA out to everybody. It's a very small niche program that we are piloting, and it's built on building on a successful previous relationship that we have with Johns Hopkins University and the NIH, specifically at Walter Sisulu, and that spanned a number of years and really had a number of wonderful outcomes and great collaborations. And we would like to see how we can build on that to increase our collaboration and partnership with the university, but also to specifically build a capacity at HDIs. It is specifically focused on HIV, and that is specifically related to the people that we've been working with at Johns Hopkins, but also the pot of money. It is specifically allocated for HIV, and that's why we have chosen that topic for the RFA. So what we want to do with this RFA is increase the participation of researchers from HDIs in our grantee landscape. We still, the researchers from HDIs are still largely underrepresented when it comes to funding that is dispersed from the MRC or awarded by the MRC. And that is really because we're not getting the applications. So we wanted to focus this one specifically on researchers from HDIs. We want to use the opportunity to increase the research capacity of HDIs and their ability specifically of the researchers to design and implement quality, innovative research projects through mentorship where required. Many of you do not require mentorship and already flying as independent researchers, but this is an opportunity if you do feel that you could benefit from additional mentorship to tap into that. It's also an opportunity to facilitate international collaboration for researchers at HDI. So often it's difficult sitting at universities very far on the, the bottom end of Africa to find and connect with collaborators around the world. And this is a specific opportunity with one of the universities that we do have very good relations with. And then finally, it's to prepare researchers for upcoming RFAs. I won't let the cat out the bag at this point, but we do have RFAs coming up this year that will be relevant, and that this program may better equip you to apply to. So I do hope that you can at least get together a collaboration and craft some research ideas. So the topic, as you will have seen from the actual RFA document, is HIV implementation science in the clinical setting. And there we're specifically looking at how do you integrate research findings into clinical care and actual interventions on the ground, and how do you assess their implementation and their impact. So it's about looking at actual HIV care in the clinic and bringing in evidence from research, or even researching how that clinical care is undertaken, what works, what doesn't work, what is the impact, etc. And it's a fairly broad topic. We do want to leave it as wide as possible and see what wonderful research ideas are submitted in response. So just very briefly, I want to take you through a couple of tips if you are planning to apply for this grant. So you need to go through these different steps. The first thing is to check eligibility, because it's the very first thing we will check when applications come in. It is only for PIs, principal investigators from HDIs, and those are the 8 universities listed there. The PIs must be South African citizens or permanent residents, and they must have a position at one of those universities. And then the second most important thing is that the project that is proposed must address the topic of the RFAs. So if it's outside the HIV field or very far removed from implementation science and clinical research, then it won't be considered. So the next thing you need to do is obviously start drafting your proposal. We have proposal and budget templates that have been provided. And the important thing is to provide comprehensive information on your proposed research project. You must develop and clearly articulate the research question, the hypothesis, and the research design. Make sure you address the core purpose, and also check what review criteria are used, because that will then guide what kind of, your proposal really needs to speak to these criteria. And you need to know what we're looking for when we assess the proposal. And that's what you really need to make sure that you address in that, the narrative. And also to mention, very importantly, we can only evaluate what you put down. So if you don't give us enough information, you don't describe the methodology, the design properly, then it's very difficult to evaluate these proposals to see if there is, they're involved robust science with technical feasibility and so on. So please make sure it's comprehensive. The next thing is we suggest input from peers. It's always good to test your proposal and your ideas again with colleagues. And of course, this is an opportunity to also test those ideas with potential collaborators in the US at Johns Hopkins University. Also have someone proofread the proposal. If you've developed it, you often stop reading it properly, and it may be that some parts don't make sense, but only somebody independent looking at it will be able to pick those up. Please make sure there are no spelling or grammatical errors. There's nothing that will irritate a reviewer more than a proposal where the PI just didn't bother to at least get all the grammar and spelling sorted out. And then also have the finance or research office check the budget. Start getting that done now, because that often does require a little bit of time. The next step is preparing the supporting documents. So you must make sure that you know exactly what supporting documents are required. Get a checklist together and start preparing and sourcing those documents. You might think that that's the quick, easy part at the end, but it could be the part that delays your submission because it takes a bit longer to get those documents together. And then also make sure that they are signed where they need to be signed. And then finally, getting it to your institutional authority early for sign-off. Our proposal template does have a section at the bottom where the institution must sign off. And if the institution hasn't signed off, then it's considered an incomplete application. And then, of course, submit in time. Do not wait for the 11th hour, because if you tell us at 5 to 6 that you had load shedding, at 5 to 6 on the 9th of February, we cannot make an exception. You have got plenty of time up until then to submit. So please do make sure you submit in plenty of time in case anything goes wrong. Laptops die, load shedding. Make sure that you don't leave it to the very last minute. And then also submit all supporting documents and through the correct channels. So don't email the wrong people. Make sure you use that email address, which is provided in the RFA document, and send through your application, your budget, and all your supporting documents before 6 p.m. on the 9th of February. And that's it from my side. All I want to do is encourage you to apply. I think the main message we try very hard to get across is if you don't apply, you will not have a chance to win grants. And, you know, even if we get a lot of people saying we don't think we can be competitive, or, you know, but you won't know until you try. So I think I really would like to encourage you to apply. And there is the link to the RFA document, but it is on our, it's on our website. And the queries can be sent to myself or Lesedi. And again, our contact details are in the RFA document. So that's everything from my side. I'm going to hand over to Bhakti to introduce from Johns Hopkins side.
Thanks, Michelle. This has been one of the best collaborations. And for me, like even as a high income country investigator, this collaboration with SAMRC changed my whole career trajectory. So I'm super indebted to the MRC for their belief in trying to work with HDIs to spur new research. So my presentation is really going to just talk us through what we did. And this was from about 2015 to 2021. So a 5-year collaboration. And I have to say the dollar amount that was invested in this work was around about the same amount as the size of these grants, right? So this should also give you an idea of what is potentially feasible to do. I'm going to talk about the research because I find the research interesting, but I'm also going to talk about how this spurred capacity development at the same time, and the number of people that were involved to make this feasible. So I think if I was going to give you take-home messages, they would be, think about the capacity you need to build at your institutions to do future research. Think about the team, and that's where Johns Hopkins University and our Center for AIDS Research and the investigators you'll hear from today are available. Think about how you build a team so you can have long-lasting career success in research. And then 3, think about what your next step is going to be. As Shelley had mentioned, there is potentially other research opportunities, both domestic and international, that you could apply for. And this is an ideal niche opportunity to get some preliminary data. So give me 1 second. I will share my screen and we'll get started. Okay. Okay. Always takes a quick second to do this correctly. Okay, so we're going to talk about the implementation and evaluation of an emergency department-based HIV testing strategy in the Eastern Cape. And this is presented on behalf of the Walter Sisulu Infectious Diseases Screening and the Emergency Department Study Team, of which Dr. Emda, who's on the call, is also a member of. So this was a really unique opportunity, actually. It wasn't an RFA that we'd applied to. It was a collaboration between the South African Medical Research Council, and I apologize, I'm going to cough throughout this presentation, and the Intramural International HIV STD Laboratory, which is led by Dr. Tom Quinn, who's also on the call. And my goal today is to present to you some background as to our work, why we felt this work was important, and then present the data from our 4 study sites. And also, as I talk through what we did and where we did it, talk about a little bit of the capacity building activities that we also supported. And I'm going to take no more than 7 or 8 minutes. And the goal is really to give folks some ideas of things they could include in their application. So emergency departments in the United States and abroad are a safety net. They see vulnerable patients, and we see high proportion of individuals who also struggle with domestic violence, sex workers, IVDU, substance abuse, intimate partner violence. We also service individuals who are missed by current health systems, i.e. patients with mental health problems, young patients, male patients, patients who are trauma victims. And we're in episodic care environments. So a high proportion of the people that come to an emergency department, they're new. They've never been there before. And what we have noted in previous research in Kenya and Uganda is HIV prevalence in this venue is high. So since 2010, the South African national HIV testing strategy mandates that there's universal provider-initiated testing and counseling in all health facilities. That includes the emergency department. But if each of you was to go to your emergency department today, I would hazard to guess that you will not be offered HIV testing because it is not routinely implemented. So as I said, this was a collaborative partnership. This wasn't a grant application, but the goal was to execute a research project, and in doing so, build local research capacity, train study coordinators, research staff, managers, build infrastructure, build the financial infrastructure. A lot of what I ended up doing was setting up agreements with Pick and Pay and other vendors so that we could pay them and procure equipment, and then setting up collaborations with entities such as NHLS. The collaboration began its earnest in 2014, but it took us years to get IRB approval. And the reason for this was at the time, the IRBs at Walter Sisulu did not have FWA. So we had to go through University of Cape Town and then have local approval. Now that through the life cycle of research development has resolved, but it allowed us to build a new collaboration with the University of Cape Town and then strengthen both IRBs through their partnership. So 2015, the IRB submission happened and we got approval a year later to do our first study site in 2016. The study design was extremely simple. So our study design was to do 6 weeks of sampling and implement PICT. We would do a combination of point of care testing and data collection, as well as a collection of rigorous demographic data, and then also collect blood samples from patients who came to the ED, those who got tested for HIV and those who did not, and take excessive sera and identify cross-sectional point prevalence and incidence. And these methodologies have been previously used in other settings. So they've been used in the United States at Johns Hopkins Hospital since 2010, where in collaboration with Dr. Quinn, we do periodic cross-sectional surveys of discarded samples to understand what the current epidemiology of HIV is in the emergency department. And we did this all under the premise of the existing HIV counseling and testing guidelines. And so the goal was to empower and use existing resources. So this is an overview of our study methodology. It was integrated implementation into the clinical care environment. So patients came in and they were triaged. Anybody who was not super duper sick, i.e. level 1, was then approached post-triage to say, hey, would you be interested in a point of care HIV test? And if they said yes, then, and they consented to testing, we would go ahead and collect demographic data and do point of care testing. And if they said no, that was okay. But if they had bloods taken during their stay, excess blood, so discarded sera that was de-identified, was then tested for point prevalence. We wanted to compare the population who said yes to testing in the ED and then those who did not say yes to testing in the ED. And also those who were super sick that we missed by exclusion at the start. Post-test, we referred individuals to linkage to care resources, but we also enrolled them in a follow-up study. So to do this work, on the face of it sounds really, really simple, but a couple of different things had to happen. We had to train HIV counselors and testers, which there was many who are unemployed, to also become research assistants because they had to participate in informed consent process. They had to participate in good clinical practice. They had to be able to collect data with integrity, and they had to maintain confidentiality. So in addition to being like an approved HIV counselor, we trained these individuals who already had one skill set to also become research coordinators. And so far, we have trained about 42 individuals to participate in these research activities across the different sites. And almost all of them have continued to go work as research staff for other clinical sites. We also had to come up with a data collection strategy that made sense. So we created this, which is a case report form, which was part of the clinical chart, so that the staff could this HIV counselors and testers could fill out information in a way that was consistent and a part of the medical record in case it informed clinical care. These sheets were then scanned into a data repository, and using intelligent character recognition, it formed a really large database of over 3,000 individuals. And we had really detailed information, including time of arrival, length of stay, and disposition, what their ED course looked like. And this generated a lot of secondary data, which I'll talk about. A part of our work included the use of laboratory drawn samples. So we had to build a partnership with NHLS, which we did. So NHLS was subcontracted from our grant to process samples, store samples, give them a study ID, and do the testing. But in many of the sites we worked at, NHLS did not have access to a -80 freezer to store the samples appropriately so they could be shipped or maintained for secondary analysis. So part of our capacity building activity was to make sure that each of the sites that we worked at had access to a -80 freezer that could then do this study, but then also support future studies. So I'm going to talk about site number 1, which is Freer Hospital. In Freer, this was like the first place that we started, and it was pretty hard, right? I remember turning up my first day to do research, and the office was filled with Ebola prevention kits, and there was no staff hired, and we literally started from the ground up. We trained individuals in extensive pre and post-test counseling. We did retraining and HIV counseling, and then we conducted all the trainings for research practice. Overall, during the 6-week period, we approached 2,355 individuals for HIV testing, and 1,852 accepted. So the testing acceptance rate was higher than expected. It was 78.6%. And we found that the prevalence of HIV was 21.6%. That's 1 in 5 patients in the emergency department were HIV positive. And then of that, 6% of patients, male and female, had a new diagnosis of HIV. So these are individuals who were unaware of their status and were not linked to care. Surprising, the peak prevalence, both known and unknown disease, was in the 30 to 39-year-old group. But we did know that the majority of our population in the ED was younger than age 29. Again, the premise here is not to share just the research, but to also think about the capacity building. So this data was interesting, right? So now we know that the majority of ED patients are young. What are the disease processes? What other research is particularly applicable to young patients that could then be initiated in the emergency department? And now we have an emergency department who has never done research before, who has, I think it was 12 to 15 research coordinators and 2 research managers, plus 2 research nurses, who are now able to facilitate other research. So when the South African Medical Research Council did their previous waves of this niche application, which was to spur pilot research, a lot of these staff, after their 6 weeks of intense training on this project, then pivoted to support other investigators at Freer. We also did this cross-sectional study, which looked at which was a discarded sera, so the blood that was taken during the course of clinical practice, de-identified, and then tested for HIV. And what we found was the actual prevalence in this population, which was slightly sicker probably, because they had routine bloods done, was 26.9%. They had similar peaks. However, what was interesting is when we calculated cross-sectional incidence, our incidence, either likely the number of people who had a new infection, was 2.57%. This is significant. This is 10 times higher than what was reported through the demographic household surveys. We were also able to collect data on how many of these patients were actually on ARVs, which was 53.4%, and only 44% of patients with HIV positive were virally suppressed. So this methodology was then replicated across 4 different sites. And again, the findings are really consistent, right? Young patients high prevalence. A lot of the patients who are positive come in with trauma. A lot of the patients who are enrolled come in with trauma-related complaints. But there was challenges to our methodology. So the volume in the ED from Freer, for example, was 9,384. And we were only able to approach 2,355 patients, right? Because we were relying just on our study staff. Like the clinical staff were not approaching patients for PICT. And then we had some individuals who also had a serum analysis, which was 2,100. Testing was only offered mostly between 9 to 5. So one of the implementation challenges that we identified was that there is a big gap here. Because HIV testing was not integrated into the clinical practice, it is unlikely that all individuals got their status. I'm going to end very shortly. There was a couple of subsequent studies. We had two one thing that we did I thought was very innovative was that we had 2 counselors plus 1 supervisor on every single shift. And we used a system of dots to track, and they were not red dots, they were green dots on patients' charts to know who had been approached, who had not been approached. We added our nursing staff to our study team, and that meant that the nurse also decreased the clinical burden and made research more palatable in the clinical setting. And then we also did some qualitative work layered onto our quant work to understand what were the reasons for accepting or declining testing. Other subsequent studies included, Other subsequent studies included using normalization process theory to understand how HIV testing could be integrated into the clinical area. We did a linkage to care study following up on all the patients who came. And then we also did GIS mapping to look at the geography of HIV service delivery. As I said, this work was not that long ago, so it initiated 10 years ago, but really concluded in 2019, 2020. So far, the parent study has 19 papers, of which 21 co-authors are from the Eastern Cape. And when we look at the Eastern Cape co-authors and their subsequent publications in the last 3 years, they've had 37 subsequent publications. Our goal really was that the bigger the team, the better. The more people that collaborate and learn through the process, the more successful we are. And I think that paid off. So as you think about your application, think about how big you can make your team and how that team can work together to deliver future research. We were also very well supported by the Research Development Program. So this grant is a follow-on from this activity that Vidya previously mentioned. And what was wonderful was when these investigators got their pilot funding, they already had program managers, study staff, equipment, resources, mechanisms available for them to do their research. The team was huge. And I just want to say thank you to everybody who participated. And I recognize I went over because it's hard to condense my research into 7 minutes. I'm optimistic, but a huge number of people contributed to this work, and it would have been possible without them.
Wonderful. Thank you so much, Bhakti. And, I think, this might have been a wonderful pet project for yourself, but without you, this it would never have happened for the Eastern Cape as well, and for researchers at Walter Sisulu. So I've known Bhakti for a number of years now, and I think of her as Wonder Woman, because she achieved all of this, and really that was through her passion and commitment to collaborate, to build the capacity, etc. Before we go on, I also just want to acknowledge, I did mention Tom Quinn earlier, but I see that Andy Red is also on. He is also one of our long-standing collaborators on this program, and it's wonderful to see you still involved, Andy, and hopefully many more collaborations going forward. So the next part of the agenda is really just a quick question and answer session on the RFA itself. So if anybody has a question, I see, is it Miriam? Did you have your hand up? Or was that just my cursor? No, I think it was just my cursor. So if anybody has a quick question on the RFA itself, you can either ask it now, or you can send a query to those 2 email addresses. We have received some queries to date, which we've hopefully responded to all of them. I'm not seeing any hands. So that's great, which means that the RFA document and perhaps my earlier presentation made it all nice and clear of exactly what we're expecting. So I think we'll move straight on then.
Shirley, can I ask a question? And I wonder if
Sure.
others may have the same question. Is when I was looking at the RFA document, it said that the length of the application had to be 6 pages, I believe. And they recognize that the turnaround time is really short. What are your thoughts if individuals have a shorter application? Would that still be considered?
Yes, so I think the main thing for us is that the application has enough detail for us to really evaluate the merits, the scientific merit. And that to us is the key thing. Obviously, when it comes to writing grant applications, there's an art to saying everything you need to say, but in as few words as possible because of limitations in lengths of proposals. So yes, it's fine if they are shorter, but so long as you've got all the information there to enable a proper technical review. Don't sell your proposal short by having it too short and leaving out crucial details.
My second question was in the RFA, we know that the ceiling is 1 million rand. Is there any items that are excluded from being in the budget?
So we prefer not to include capital equipment. We expect the university to provide the basic infrastructure and equipment. We really want the funds to be used to support the people and any direct costs to do the research. We haven't allowed for a travel budget for one international trip if necessary for to encourage the collaboration or to allow for the mentorship and direct in-person exchange with the collaborators.
Yeah, and just to be clear, everybody, that the budget will only include expenses for our HDI participants. The collaboration with Johns Hopkins University will be in kind. But I think having travel costs included may potentially be beneficial. So your collaborators could come to the site and provide direct hands-on support, and that would be permitted.
Yeah, so that's
I see one more hand. I think we just need to get some questions going.
Yeah, Nabukle, go ahead.
Good afternoon. I am from Mangosu's University of Technology in the Department of Biomedical Sciences. So thank you so much for this webinar. My question is regarding the institutions. I saw the list of institutions, but I just wanted to find out if we are allowed to perhaps collaborate with an institution that's not on there and submit a project, a South African institution.
So absolutely. The research we support as the MRC, as far as possible, we encourage big collaborative, multidisciplinary projects because everybody brings something to the project. What we do ask in this case is that the lead PI is from an HDI and that most of the work is done at the HDI. But we have no problem with including collaborators from other universities. They just cannot take the majority of the budget, please. Okay, any other questions? Wundle.
Thank you, Michelle. Just to clarify, so if I'm at the MRC, if I partner with someone who's based on an HDI and the person is the lead PI, so most of the funding goes to them, can some of the funding be allocated to someone at the MRC, for instance, for some of the activities in the study?
It can, so long as it's not a substantial proportion of the budget. And also so long as that collaborator from another institution is undertaking a key part of the research that could not have happened at the university itself. So, if you're undertaking or providing a key a bit of expertise that the project really needs and is not available within the research team at that university, then by all means we are fine with that, and that would be a sub-grant from the HDI or the host institution of the PI to you, whether you're at the MRC or any other public institution in South Africa.
Okay, thank you.
Okay, so I think there is still an opportunity for you to send any further questions that you might have to the emails that are provided in the RFA document. But I think let's move on now. Bhakti, if you would like to introduce the presenters from Johns Hopkins, and they will each have an opportunity to present.
Perfect. So the purpose of this next part of our session is to just give you some connections that you can follow up with after this call. So the three individuals that we have chosen to present are part of the Center for AIDS Research at Johns Hopkins University. They're implementation scientists whose work primarily focuses on HIV. They have ongoing research activities already in South Africa, but I'm hoping that some of their work, if not much of their work, will lend itself in new collaborations with HDIs. So without further ado, I'm going to ask Chris Hoffman. Chris, is it okay if I ask you to present first? Wonderful. So Chris is actually a long-standing mentor of mine. I've known him for about 10 years. He's a wonderful human being, but also he's an associate professor in infectious diseases. He's an implementation scientist. His research interest really focuses on care delivery and care utilization and the management of HIV and TB in low resource settings. Some of his really innovative work and focuses on populations such as prisoners in low resource settings, which I think is really trying, again, beyond the ED, closing that gap in service delivery. Chris, let me hand over to you to share with us a little bit about your research and the methodologies that you utilize.
Great, thanks so much, Bhakti. Hopefully, individuals interested in this RFA are already well on their way to, hopefully you're well on your way to developing concepts. But I just wanted to, or Bhakti asked me to present a little bit of work that I do, and I think reflect on how that can, how that's related to implementation science, and how the journey of implementation science can work really for many researchers. So I would just say, starting with my path, I've spent the last 15 or almost 20 years working, doing a lot of work in South Africa, mostly with the Oram Institute in Joburg and PHRU in Soweto. I started with doing outcomes research using large data sets, but shifted into implementation science to better understand why services were or were not reaching populations that could benefit, and then how to better deliver those services. And as Bhakti said, a lot of it is with health service delivery, and much of it is around HIV and the HIV care continuum, from HIV testing to HIV care engagement. And then, as Bhakti mentioned, some specific populations, people living with HIV and having been incarcerated or currently being incarcerated, and or with substance use, as well as individuals with advanced HIV disease. So before jumping into some descriptions of what I've done, I think it's useful to take a step back in terms of what implementation science is, which is meant to be a focus of these grant applications. And directly from this request for applications is a definition to promote the integration of research findings and evidence-based interventions into healthcare policy and practice, and hence to improve quality and effectiveness of health services and care for people living with HIV. There are probably more definitions of implementation science than there are researchers. I think the simplified way to look at it, and that can be justified pretty much for any RFA, is that we know that there are effective interventions, and many of these interventions are not reaching all the people who could benefit. Either there's specific population segments that are not receiving them, or overall the implementation is low. And implementation science is about building a bridge to more complete implementation of that intervention. And as I think probably everyone on this call is aware, that many interventions, whether it's control of high blood pressure, whether it's TB prevention or other services, only reach 10, 20, or 30% of those who could really benefit. And one example is even with antiretroviral therapy, where there's obviously a large and a very effective program in South Africa. Only an estimated 69% of people living with HIV in South Africa have an undetectable viral load, which is well below South African and WHO targets. So moving on to my take on implementation science, the field, I would say, initially and sometimes really focuses on the service delivery side, whether it's at the very top with policy or how the healthcare worker is interacting. And you can see a list of different levels. I won't go through all of those, but at some point, the health system is interacting with a patient or a population. And this is often described as the inner setting, maybe a care setting or a public health type setting. And for that intervention to be effective and actually reach people, there needs to be an interaction in that intersetting with the patients and service uptake. So in terms of implementation science, certainly engaging and figuring out how best to engage patients or populations in receiving and accepting and utilizing those services is also a critical component of implementation science. So jumping into a couple of examples of work that I've done. One was focused on trying to understand some of the factors or determinants of HIV testing within public health clinics in Ekurhuleni, South Africa, in order to try to increase the HIV testing, at least to the clinic clients that may best benefit or most benefit. And this was in collaboration with the Orem Institute and the South African Department of Health, and really using a lot of quality improvement approaches. Overall, we used a systems analysis to understand the level of HIV testing at that time in 10 clinics and opportunities to improve or increase testing. We measured the amount of HIV testing, mapped when testing was occurring, conducted a lot of qualitative work.
I'm on webinar.
Discussed with the health team in the clinics in terms of change approaches, as well as just how things were going. And then with the clinic teams from the clinic manager, HTS counselors, nurses, other health staff and clinic staff, developed some change interventions. I'm not going to go in order of what we did or present everything, but just in terms of the one of the things we did was process mapping, which what we did is we just followed clinic clients through their journey from arriving at the clinic to leaving the clinic, and measured how much time they spent waiting and how much time they spent actually receiving a service, whether that was at the help desk, reception, having vital signs assessed, or in consultation with a nurse or doctor, having blood draw, or going to the pharmacy. And initially, this top figure shows the time that with the up boxes where they were receiving a service, and the bottom boxes wait time. And here at the end, you can see when they were offered HIV testing, and then the time spent for HIV testing. And the offer of HIV testing was occurring for the majority of patients, after they'd already spent usually around 2 or more hours in the clinic, and only after or at the end of a consultation with a nurse or doctor. We also observed, obviously, all this wait time, so opportunities to provide HIV testing that could actually shorten the entire clinic visit. And all of the clinics wanted to change when HTS was offered, HIV testing services offered. And for the most part, it was HIV testing was offered after a patient was initially enrolled in the clinic. And then they could go right for HIV testing, although usually went after getting vital signs, but then they had the HIV testing results prior to seeing the doctor or nurse. And that cut out, for the patient's perspective, about 40 minutes of their clinic visit time, and was able to increase the amount of HIV testing. I'm going to skip this, but going through this, but I just wanted to highlight that we worked again with the clinics to come up with approaches. Each clinic could develop or adapt its approach as desired. In terms of the change in HIV testing, prior to or baseline, in this red box, it shows here 10% of all clinic clients were offered HIV testing. And some of these individuals were there for HIV care, so we didn't try to just differentiate. This is all patients coming to the clinic, 10% were offered HIV testing. After making these changes, 34% were offered HIV testing. And of those offered HIV testing, the majority went for HIV testing, somewhere around 90%. I'm going to, do I have time to keep talking, Bhakti, or is my time over?
I think you can carry on for a few more minutes, then
Okay.
we'll hand you over to Jason.
Great. So the other rather different study I wanted to mention was working with formerly incarcerated individuals to increase care continuity for HIV after release. So globally, in South Africa, in the United States, in Europe, in Asia, even though antiretroviral therapy may be provided while people are incarcerated, after release, the majority of individuals who were on antiretroviral therapy do not continue antiretroviral therapy. There are various reasons for this, and they differ slightly from one country, one area to another. So working with very closely with formerly incarcerated individuals, we did really is community engaged research, trying to understand, before even understanding what their barriers were, just talking to them to understand what their goals would be for us to find out. And this was, we did mixed methods to understand barriers and needs and desires of after release. And this was in collaboration, again, with the Orem Institute, with previously incarcerated people, the South African Department of Correctional Services and South African Department of Health. After considerable time doing this formative work in collaboration with both the Department of Correctional Services and focus groups of previously incarcerated individuals, we developed an intervention, which was a group peer-based curriculum that met every 2 weeks for 6 months, loosely based on community adherence clubs, with antiretroviral therapy distribution during group meetings, with the goal to increase the perceived value and decrease burdens of accessing antiretroviral therapy to overall increase HIV care engagement for this population. And there are a lot of challenges that are somewhat unique to this population compared to the general population of people living with HIV. And it's a big change going from incarceration, where there's high levels of regimentation, lack of privacy. Resources are essentially provided, food, medications are either brought to an individual or they're escorted to a clinic, antiretroviral therapy directly provided, highly regimented, where individual autonomy and decision-making is suppressed and really not desired, compared to a community setting where there's considerable autonomy, anonymity as well. Resources need to be sought out and struggled for often. There may be very little social support. Families may reject people because of their incarceration history. And antiretroviral therapy has to be sought, and there can be barriers at the clinic level, including stigma against people who were previously incarcerated. So we enrolled individuals prior to release from a correctional facility and then randomized them either to the Transitional Community Adherence Club intervention or usual care, which was a referral letter to clinics. And these groups had 4 to 8 members. They were led by a trained peer and social worker, met every 2 weeks, and had a fairly structured but adaptable curriculum focused on needs of individuals returning to the community. And antiretroviral therapy was provided in group sessions, and they lasted 6 months. And this increased, this year's the primary outcome, increased care engagement by about 70% from around 36 to 61% of individuals in HIV care on antiretroviral therapy 6 months after release from correctional facility. Here on the right, just really quickly, this is subgroup analysis, very small numbers. This was a pilot study, but this was really done as exploratory work. And you can see here in the red box, individuals who are using opioids daily, whether it was within the correctional facility where there's relatively easy access to opioids and other substances, or in the community where there's also easy access to opioids. Those individuals did not benefit, while those who did not use opiates were benefiting. So follow-up work has been to really implementation science, again, to understand needs of individuals living with HIV and opioid use, and understand how services can be best delivered to those individuals and what services they actually would be interested in. And I mentioned that partly because certainly in this population, substance use is a growing issue. And I think overall in HIV care in South Africa, certainly in some areas, there's a growing challenge with substance use. So just really in summary, implementation science should not scare anyone. It's really about identifying current gaps and then thinking about how to determine what may be causing some of those gaps and then coming up with potential solutions. And certainly I encourage everyone who's thinking about applying to do so, and others who are eligible to apply. And as I think Bhakti said, with this, even though it's called a pilot grant, you can do quite a lot with the potential funding and really make a big difference in improving individual and public health, which I think is really what we're all about. So thanks so much for the opportunity to share.
Thank you, Chris. I appreciate your presentations as always, because you take it back to the big why. Any questions for Dr. Hoffman before we move on to our next speaker? Okay, so without further ado, I'm going to introduce Dr. Jason Farley. Dr. Farley is a professor at the School of Nursing. He's director of the Center for Infectious Diseases and Nursing Innovation and co-director of our clinical core at the Center for AIDS Research. He's had several R01s, one of which is to design to tailor nurse care management for persons with drug-resistant TB and HIV co-infection in South Africa. And he's also a co-investigator on the Adaptive SMART trial, which is an adaptive randomized evaluation of nurse-led HIV treatment and retention interventions for female sex workers also in South Africa. All of the speakers today have slightly different geographical relationships and foci, And I think Jason is actually closer to the Eastern Cape in some of the work that he has done. So Dr. Farley, I'll hand over to you. Thank you so much for taking the time to join us. He's going to be in South Africa tomorrow. So for this, oh, he's there today. So there's potential for in-person engagement as well.
Hi, everybody from Gaberha. I'm here in PE doing some great collaborations with some colleagues and friends. So I'll share. Thanks so much, Dr. Hansoti, for the opportunity to discuss. And I've decided to tell you about two potential studies, one currently recruiting and enrolling, the first one I'll talk about, and one that's got a substantial amount of data available for you. Now, you'll note that this RFA specifically calls for HIV funding, and although you'll see on the title of this slide that this is a population of people with rifampicin-resistant tuberculosis, approximately 65% of our patients in this trial are co-infected. So, and we expect that trend to maintain throughout. Also, for those that are HIV negative in our study and in our work, we're actively looking at how our clinicians will offer HIV prevention services, including pre-exposure prophylaxis. So there's opportunities to think about that as well. So the Bring Big Pal to Me trial is an NIAID-funded, cluster randomized, non-inferiority trial that's looking at nurse-led primary care treatment compared to physician-led models for rifampicin-resistant tuberculosis. It has three main aims. For summary purposes, just to go through the highlighted parts, we're looking at successful treatment outcome, and our hypothesis is there will be equivalence or non-inferiority between the nurse-led model and the physician or medical officer-led model. The severe adverse events will not significantly differ, and the catastrophic cost will be lower. So we're working with Hero at WITS to perform our costing and cost effectiveness analysis in the trial. And we're going to be evaluating a host of secondary events, including time to HIV treatment initiation, viral suppression, adverse events. And all of these secondary aims are open for potential nesting sub-studies within. We have the staff and the infrastructure. So if you haven't started and got a great idea on your proposal between now and February 9th, you don't have a lot of time. Happy to talk to you about ways in which you could nest within this work. But to give you a slight overview, similar to Chris, we do a lot of process mapping in our work. And so Dr. Hoffman's team, and Dr. Hansoti's team and the way they think about the processes and structures, what you can see here, our team has designed the current standard of care for drug-resistant tuberculosis and HIV management for people diagnosed with drug-resistant TB in the top gray box. And it typically means referral to a centralized, some decentralized, but a lot of centers of excellence and principal decentralized sites are hospital-based. And we've got data, and I won't present today, but distance to treatment is a key social and structural barrier for populations with TB. And so in this study, in the yellow, what you can see is that we've randomized primary care clinics, which are our clusters, to either nurse-led treatment or physician-led treatment, which is following the standard of care in that clinic. So some clinics who are randomized to the physician will have standard of care delivered at the centralized hospital site as per their standard, and others will have a medical officer initiating treatment directly on site. So depends on what the standard of care in that particular arm will be. So we form the clusters. Each primary care clinic is a cluster feeding into a community health center or a large primary care clinic. And it kind of works itself out like this. So you can see here that you have sub-districts, clinics, whether or not, depending on the size of the clinic, they may form a single cluster, or you can see in cluster 5 there, they have so few RIF-resistant TB diagnosed in a single year that they form a cluster of geographic smaller clinics that together will equal a single cluster. And then you can see that we have sites of initiation that vary in terms of the total primary care or CHCs that may be referring in. And you can see that we've randomized them based on a variety of factors, but cluster size being one, to either the intervention with the clinical nurse practitioner or the comparative, which is the medical officer. And so we have a variety of interesting selection criteria for the trial. You can see the ones that are inclusion in blue and exclusion in red. And why this is critical is because one of the principal implementation questions we're trying to answer with the trial is who is the appropriate patient who should be managed in primary care for drug-resistant TB, because we clearly know that not all patients are appropriate for primary care management. And so if you look at the red, I think the blue are self-explanatory, but the red, any patient who requires, whose clinical presentation requires hospital referral. And I'll show you some data on the screenings we've had to date about late presentation to care, often with untreated HIV, extremely low CD4 counts, and drug-resistant, newly diagnosed drug-resistant tuberculosis, and how we need to work better on getting people engaged in care. There's a couple of laboratory parameters, QTC the ECG findings that help us evaluate the rate of the patient's heart and the QT interval. Pregnancy is excluded, extrapulmonary TB, and prior treatment with BPAL. Now, all of that taken together, when we look at enrollment, you'll begin to see a picture of one of our implementation science questions, which is who can be appropriately managed in primary care. We've received a referral for 184 people. Our 3 sites are in Gaberha, in East London, as well as in etiquette in Durban. So we've had 184 referred patients, 42 not meeting initial study criteria, with 142 evaluated by one of our clinical team, 37 of those not meeting a clinical exclusion for primary care management, and then randomized, and you can see, into the 2 arms of the study. And principally, you can see here that 22 patients, for example, presented to the TB focal nurse for their original diagnostic testing for TB with severe weakness, being unable to walk, unable to stand. And that's been the major pre-clinical team evaluation exclusion. So again, that late presentation to care. And in below, in summary, the 2 major reasons that people are, being excluded from the trial is that, again, late presentation to care, severe weakness, to the point where there's maybe confusion, severe mental illness, maybe someone's presenting with extreme effects of substance use disorder. And then we already see a lot of patients, principally either because of untreated TB or untreated HIV, who present with significant anemia with a hemoglobin before 8 at baseline. So, but one of the key questions for this data, and why I'm presenting this, that we are asking, it would be a great potential sub-study for this parent study, is if we were to follow all the patients excluded from the primary care model, which, by the way, align with the South African treatment guidelines. If we were to follow what the guidelines say and what we've excluded in the trial, what is the clinical outcome of those patients? Could they have actually been managed? And if so, what groups, what phenotype of patients could have been managed at primary care, thus saving them tons of money, resources, and time? So a little bit about who we've enrolled in the protocol, and this is just through the December 31st. The majority were male, approximately 40 years of age, 65% living with HIV, mean CD4 count 239. Only 5% were virally suppressed at the start of the new regimen. But we are reducing time from diagnosis to treatment initiation. And the new, typically in the country, we see around 14 days. With the protocol so far, we're seeing about 6 days, nesting this in primary care. For those being on treatment for at least 1 month, it's about 65% having an AE, with the mean time being 7 days. Another implementation science question we're asking is the clinical guidelines say you don't need to see someone for the first 2 weeks of treatment in primary care. And we are saying we're going to see the patient weekly to see how quickly adverse events are occurring and can we prevent people from being lost to follow-up. You can see the 3 main AEs that are patient-reported and our lab-based report of AE in the first 4 weeks is anemia, with approximately 32% experiencing anemia. But with many patients now reaching month 4, month 5 in the protocol, to date, we've had no loss to follow-up and no deaths have been reported amongst the enrollees, which is a critical feature in this protocol. So with that, that's an ongoing study, the potential to nest questions prospectively, potentially add your own questions. This is a data set that is a cluster randomized trial that has been completed. And just quickly, patient-centered models of care are often lacking. We don't have really great descriptions of what exactly patient-centered models of care are required. So this was a nurse case management model that we looked at. And for the sake of time, I'm going to breeze through this, but we had 10 MDR-TB hospitals across the country. We finished the trial in the middle of COVID 2020, where we were shutting down the sites. We used generalized estimating of questions for multinomial outcomes. And I won't go through the full model, but just to say it was an implementation science chronic care model designed to improve all the things in the middle of those boxes, leading to improved outcomes. And so we have about 2,136 people in the intent to treat analysis. So it's a large data set. A lot of questions around adherence can be answered with this data set. Because of time, I'm going to keep moving, but you can see some of the demographics. Again, a large proportion of people, here are their HIV characteristics. In this data, approximately 74.3% were living with HIV. Most not virally suppressed upon entry. And interestingly enough, one of my PhD students did a nested study within this work showing that the majority of patients, slightly less than the majority of patients, about 46%, completed their entire MDR-TB treatment and yet were not virally suppressed upon completion of a 24, 18, or 9-month MDR-TB treatment regimen. So was it successful? When we looked at it dichotomously, success versus unsuccess, the answer was no. We never proposed to do it dichotomously. It was always a multinomial outcome. And what the take-home message here is that nurse case management successfully reduced treatment failure by 45%, really showing that what the nurse was capable of doing was improving patient adherence in this setting. Loss to follow-up was not improved, and it's because of the social and structural determinants of health that we were not able to address with financing models or other things in this particular study. So the key thing that is a potential really great nested study is the fidelity to the intervention was really nurse dependent. And while we monitored it throughout all sites, one really important question that could be answered with this data set is, did sites that have more fidelity to the nurse case management intervention ultimately, even though it was successful in reducing loss to follow-up, was it successful with sites with more fidelity to the intervention have greater impact? So tons of partners that are available upon this study. And so as you think about big teams, the study does come with the current active study, as well as the prior work comes with a pretty large bench of people that can provide mentorship. So thanks.
Thank you, Jason. And there's a number of people that are direct messaging me for your contact details. I just emailed you too. I messaged you too. If Chris and Jason, if you're interested in supporting some of these collaborators to recreate these studies or expand these studies to other venues, then feel free to go throw your email address in the chat. I didn't think this would go on for 19 minutes, but it's really hard to talk about this amazing work in 5 to 7 minutes. So I want to hand over to our next colleague, Dr. Cherie Schwartz, who unfortunately had a meeting, so wasn't here for the earlier part of the call, but is here to share a little bit about her research. So Dr. Schwartz is an infectious disease epidemiologist and implementation scientist. She spent 6 years based in Southern Africa and Mozambique and South Africa, working on public health and HIV program implementation. And then she switched to the research side as her career progressed. She's been working in South Africa since 2008 and had a number of partners locally. She's also the co-director of our implementation science core at the Center for AIDS Research and is a part of the Center for AIDS Research Executive Committee. She also has several roles that are focused specifically on implementation science capacity building, given that she's the director of an implementation science fellowship for early stage investigators. She's a phenomenal mentor and has an expansive breadth of work that I hope is opportunities for some of our HDI investigators. I'm going to hand over to Cherie. Thank you so much for taking the time to join us today.
Thanks so much, Bhakti, for the kind introduction and for having me. And hello, everyone. Sorry for being late, but really lovely to see that there's so much interest in this. So do we have like 5 minutes, Bhakti, just so I can sort of
5 to 10. It'd be good. So we have
Okay.
10 minutes for Q&A at the end.
Okay.
Sorry, but I just want to allow time also for there is at least one presenter from South Africa, so we do need to just allow time for that.
Okay, so maybe I'll go without slides and I'll just say a little bit about, because I'm sure if I show slides, it will start going on and on. But we have, we've been working, I've worked with multiple partners in South Africa and currently have work ongoing with Desmond Tutu Health Foundation, but primarily with TB HIV care, which is kind of some of the studies that I think potentially could be interesting. So TB HIV care, you know, they're an implementing partner that gets funds from, you know, some from Department of Health, but largely from PEPFAR, Global Fund, other donors, and they implement some of the biggest. They implement some programmatic services for those living with HIV more globally, but really have where I've partnered with them alongside Steph Barral is work ongoing with key populations and priority populations. So they have the largest program serving female sex workers in South Africa, where they provide both HIV treatment for those living with HIV and PrEP programming for those that are at risk for HIV infection. So, and they're also working, they have a large program with adolescent girls and young women funded through the DREAMS initiative. And so where we've had really successful implementation science partnerships with TB HIV care is that they have these large, you know, these large programs that are being implemented that are reaching, you know, 40,000 women with PrEP. And we know for something like PrEP, as an example, that you know, the demand is increasing, but the persistence for those staying on PrEP beyond that first, you know, that first month, or maybe coming back at 1 month, but then not coming back at 4 months, it's really kind of a cliff. And so where we've really been focusing is trying to understand programmatically what's going on. We've done fidelity assessments within the program just to observe. We've done quantitative and qualitative interviews with providers. And then we have a very large individual level cohort that is just being finalized that will have about randomly selected female sex workers and adolescent girls and young women who've started PrEP over the last 8 years. And so it's an individual cohort of about 18,000. So those data are, I think, will be a very interesting data set for folks that might be interested in some of those issues that we would be actively you know, looking for folks to engage in analyses on. And then embedded within these programs, we've done it with the treatment program, we've done it with the PrEP program, we've had some NIH R01s, R21s focused on optimization of services. So we've had sequential multiple assignment randomized trial to sort of test strategies out and then adapt them if they're not working well for folks. That was a treatment focused study where we had, you know, all sorts of quantitative data collected, lots of qualitative data as well, using implementation science frameworks. And some of those, a lot of those data are still under analysis for the trial that ended around treatment. Within our PrEP R01 that I lead, we have 2 small short duration trials. The first one was a cluster randomized trial focused on changing social norms. And we have all sorts of, you know, fidelity assessments, provider data, as well as end user data. And our providers or implementers, you know, are very varied. So we had community mobilizers and looking at the fidelity of utilizing community mobilizers, as well as some of their experiences of working in communities trying to affect social norms around PrEP. We also have another individual randomized trial that's just starting that uses a fractional factorial design. And so there will be 16 different arms. So there's 4 strategies that are being tested and they're permuted in different ways. So you could get one of 16 arms, and that will be starting in Pietermaritzburg in the next month. So that will be gating qualitative and quantitative data there as well. So I'll try and be short, but just to say that there's a lot of different opportunities for those that are interested in qualitative work, quantitative work, fidelity focused, many different, you know, types of things ongoing. We also have an R21 focused on substance use amongst female sex workers living with HIV and using discrete choice discrete choice experiments to engage preferences for strategies to integrate within service delivery. So a lot of different things going on if you're interested in some of these behavioral questions and marginalized populations. So thank you. Feel free to reach out.
Thanks, Cherie. And one very specific question for you is there a Center for AIDS Research email that folks can email if they're looking for a mentor or a collaborator? And it doesn't fit between the 3 people we've had present today, but I wonder if there's other individuals, either in the implementation science fellowship, that may be already working in some of the areas that we're focused on. Who can folks contact?
Yeah, that's a great question. I think for anything implementation science focused, I mean, you could feel free to reach out to myself or Steph. We co-direct the core, or I will share the email address for Anna Katomsky. She's our coordinator, so she could also help link folks. So I'll put her address in the chat as well.
Thanks, Cherie. So I'm really excited to shift gears a little bit because if you're like me, like having the 3 of you guys present is a little overwhelming. You're doing so much amazing work. But I really wanted to hear from one of our local investigators. Shelley, would you care to introduce one of our colleagues who's thinking about applying for this award?
Sure. So we have a request from Professor Basson, who has sent through a presentation. Prof, would you like me to share from my side?
Yes,
Prof.
please,
Basson?
Michelle, go ahead. Thank you.
Okay. Just let me know when it's in full screen mode and visible.
Okay, it's good. I can see that. Okay, thank you. Yes, thank you, Michelle. And thank you, everyone. Good day, wherever you are. I think what I'm going to present today is simply what we are doing. And I'm speaking on behalf of the team. This is an SAMRC extramural unit at the University of Venda, which is its main goal is on antimicrobial resistance and global health research. But for today, I will speak. I will focus on the aspect of HIV drug resistance. Next slide, please. So in general, we are more interested in the biologic and psychosocial determinants of resistance to first-line therapy. And the goal is how we can sustain the efficacy in the sense that second and third line drugs are more expensive and also come with other side effects. Next line, please. So one of the study we did, which was a cohort, was a prospective cohort. We looked at patients who are about to start treatment on the first at different clinical sites in Limpopo province. And in the summary of that outcome is that and before they started treatment, the cohort, this was about 500 participants. Employing the NGS technology, were able to detect a 5% of surveillance drug resistance mutations, of course, at the 20% sequence threshold, and up to 12.9% at the 5% threshold. So that for us was pretty high in terms of and the WHO standards. In another previous study we did, it was below 5%, and we had the feeling that as the access to treatment expands and continues, perhaps there is a transmission of HIV drug-resistant viruses in the communities. Next slide, please. So in that study, we tested to see all the participants have answered no to a question whether they have been exposed to any ARV in any form prior to starting treatment. So when we find out that we have a significant proportion of them who are carrying drug-resistant mutations in the viruses, we did an approach which we think is more objective in looking at the hair and plasma, and to detect the presence of a certain concentration based on standards of exposure to antiretrovirals. And in that nested study, we had 77 participants, and 31 of them were shown to have been exposed to tenofovir, which, as you know very well, is one of the backbones of the first line treatment. Next slide, please. So we also did a review, a national review in terms of previous studies where it's been documented in terms of resistant viruses, if they are low, high, or say moderate. Well, next slide, please. And we saw that at least out of the 9 provinces, at least in 8 of the provinces, there is a community that has at least a moderate or a high level of drug resistance in the population. Next slide, please. So we derive an hypothesis, we'll say 2 hypotheses, in the sense that we have a significant proportion of undisclosed exposure and to ARVs, and there's a potential of this impacting viral suppression, and of course the sustainability of antiretrovirals in terms of the first-line treatment. Because if I have been exposed to ARVs and perhaps I have developed resistance, that is not picked up in terms of the screening of the participants who are entering treatment. So if I have developed resistance, I may not derive the full benefit as much as it may be, I would say, optimal benefit of the treatment on which I'll be placed on. And based on the pre-study, we also think there are issues of mental health, which we have influencing, also driving the non-disclosure of prior exposure, and also driving exposure to ARVs outside the clinical context. Next slide, please. So this is an ongoing study, which in a way to say, what is the real burden? What would be a good estimate of that burden in terms of prior exposure? And to be able to assess that, we need to set up a cohort and follow that up, and to see those who are entering that cohort and follow up in terms of and the characteristics of those entering that cohort and how that influences and treatment outcomes, at least in the next 1 or 2 years. Next slide, please. So we have collaborating sites in the 4 districts of the province of Limpopo, which I recruit participants who are about to start treatment. And also, next slide, please. Also, we have Gloria also on this call, who is a collaborator from the Sefako Makato Health Sciences University, in Garankuwa. And so we want to have a broader geographic view in terms of what actually obtains. And next slide, please. So our idea is that very likely it is important to really draw the line, what is true naivety in terms of exposure to treatment. And the standard protocol is that in terms of the diagnose and treat protocol, I get diagnosed, I'm screened, I'm asked a few questions, I answer self-reporting style, and I'm placed on first-line therapy if I don't have any other contraindications. And we think perhaps there are a few questions that and that patients need to be screened for, again, to enhance and subsequent outcome on the treatment on which you'll be placed on, or perhaps even to direct the type of treatment on which you'll be placed on. And of course, the aspect of the UNAIDS goal, one of the goals is that all those on treatment, 95% of them should be virally suppressed, and prior exposure may be a massive hindrance based on the pre-study, the pre-data that we have. Next slide, please. So thank you. So the goal of this short talk was just to say, and this is what we are doing, and how does this data actually fit in terms of implementation of research going forward. Over. Thank you.
Thanks,
Thank you very much. Go ahead, Bhakti.
I was just going to ask Prof to put his email address in the chat. We do have a number of Limpopo investigators on the call right now, and so I wonder if there's some opportunities for local connection too. So I think with that, we'll move on to Q&A. So there's a couple of questions and answers that came through the chat. One was, do I need to have IRB approval prior to the proposal being submitted? I don't think that is necessary. I think you need to have a well thought out study design. But if you do have IRB approval, I think it's worth you mentioning that in your applications that significantly increases your feasibility of doing this work in a timely manner. I think we're gonna, if there's any other questions and answers, Shelley and I can try and take them right now.
I think also, you know, if anybody wants to just very briefly outline some of the ideas to see if there is anybody else on the call, or it triggers any possible names to put forward from Johns Hopkins for you to contact, that this is also an opportunity for that.
Yeah.
Prof. Pasang, have you got your hand up? Or is that just...
No, no, my hand is
Prof has
not
put his
up.
email in the chat, which is great.
Yeah, you're wonderful. So I think the other, you know, if anybody else wants to be contacted or, you know, express interest, they're also welcome to put their email address in the chat. With the POPIA, we are no longer allowed to send out just a list of everybody's email addresses. Only, you know, we have to get specific permission from everybody. But what you can do if you do want to be connected to anybody on this call is to direct an email either to myself or to Bhakti, and then we can put you in touch with the person that you might have identified. But other than that, I think really what we wanted to showcase here was the benefits of this kind of program, but also that there is some really fantastic research happening at Johns Hopkins, which I think is directly applicable to the work that you might be doing in South Africa. And even if nothing specifically on today's call resonated with you, if you have a specific idea and you're looking for a potential collaborator, you can send a paragraph or even just a project title to myself or Bhakti to forward on to the right people at Johns Hopkins to find potential linkages for collaborators.
Agreed. And then Prof. Pasang, I just want to alert you that there's a message from Jason Farley for you. Any other parting remarks before we close and I go refill my cup of honey and lemon, which is...
I don't know. I can't see my book. It's a Rukasha from Limpopo here.
Hi, Ivy.
Yes. So I wanted to ask, so should we not receive a response and you really want to apply? Like in my case, I really want to apply, but I'm just scared that after the call, I might not receive the response from the person I'm trying to reach out to. So what do you do now? Do we have you need to have a collaborator to reply you for you to apply for this grant? What do we do?
So you do not need to have a collaborator. The primary purpose of this award is to support HDI investigators. The mentorship and the collaboration are opportunities to strengthen a potential application, leverage existing resources, existing methodologies, and existing approvals. But if you have an application and you feel like it is a solid application, you don't need a collaborator, you can apply for it without a collaborator. I recognize that, you know, it's really frustrating when you're sending an email and no one responds. You know, I think the challenge nowadays is people are just overwhelmed with emails, but also people are traveling and so may not have access to their internet. I would suggest that if you're really not getting a response, feel free to reach out to myself, Shelley. I think Tom Quinn was on this call as well. He's the director of the Center for Global Health at Johns Hopkins University. And all three of us will work to advocate on your behalf. Sometimes things go to spam when it's an email address that's not recognized, and that could be a problem too. And so if you email from a Johns Hopkins address, you are more likely to sometimes get a response. So I'll put Tom's email address in as well.
And I think linked to that point, if you could use your university address, preferably, because often a Gmail address will go to spam. And I think also, put in the project in the subject line for the email, reference this RFA, so people know to specifically look out for it and to give it the attention needed.
Don't get frustrated. We'll find the needs that you have.
Yeah. I have specifically wanted to link with Prof. Jason there because he's working exactly in the field that I am in. And yeah, I hope, yeah.
Well,
Hi,
Dr.
Ivy.
Farley's still online, so
I've already responded to your email, Ivy, since we've been on the link.
Yes, let me just take advantage. Yes, I really wanted to say that's the field I am. I hope he replies me. Okay.
Thank
Yes,
you,
I've
Jason.
no worries.
Okay, any other questions? Real-time networking. This is what there's some advantages to multitasking.
We call it speed dating.
Okay, well, everybody have a blessed day. We look forward to receiving your applications. We look forward to seeing what's generated from this funding opportunity. And I hope it can continue the capacity building that was already started almost 10 years ago.
Wonderful. Thank you very much, Bhakti and team, and the researchers from Johns Hopkins, and to all the participants from South Africa for your interest and spending the last 90 minutes with us. And I hope it's been useful for all of you. So thank you, and we look forward to receiving your applications.